Hi everybody, my name is Charlotte.
My name is Brooklyn.
And we are student physical therapists explaining our case today. So our case includes an 85-year-old male who is being seen in an inpatient setting. We are treating him for general deconditioning, but we are unsure of his initial diagnosis. So general deconditioning, specifically in the hospital, can also be called hospital-associated deconditioning, or HAD is what it's called. And basically that means that this patient is having pretty rapid muscle loss, atrophy, as well as feeling a lot more shortness of breath with exertion. Things are just a lot tougher for this patient to do activities of daily life, which Brooklyn will touch into. But strength and endurance are basically being affected due to the prolonged inactivity occurring in his bed rest state. So Brooklyn is going to touch in on some common impairments with that.
So since this is a systemic condition, it really affects like every body system that we have. So we're going to talk about the different systems. Cardiovascular, let's touch on first. It has decreased stroke volume and cardiac output as a result of the deconditioning. So generally your heart rate increases with like any normal activity, and it just takes a lot, or it's a lot more work on your heart to like do normal things. The pulmonary system, you generally have increased work of breathing, decrease in maximal O2 uptake, decreased efficiency of oxygen use, stuff like that. And like what Charlotte said, a lot of shortness of breath with activities. Musculoskeletal, you have a lot of muscle atrophy, which gets worse the longer you're immobilized for. Decreased bone mineral density, leading to osteoporosis, joint and muscle stiffness, and then just a lot of like generalized weakness. Neurological system can have a lot of cognitive declines, depression, anxiety, and then even impaired coordination/balance, which is really important. And then in terms of your like metabolic system, decreased insulin sensitivity, and then generally increased BMR because your body's having to do like so much extra work to compensate. And then this comes with a lot of functional limitations, like I said, because it's a very general diagnosis and it affects like everything. Functional limitations include decreased ability to perform ADLs due to decreased capacity to do work, decreased aerobic capacity, especially that's seen a lot with like ambulation, decreased muscular strength and endurance to perform activities, increased fall risk due to that weakness and that lack of coordination, and then overall just like decreased quality of life.
Yes, and one thing I did want to touch in on before we head to the next segment is that signs and symptoms of general deconditioning can look very different for different populations. This is more generalized for the older populations, but just because that these are some signs and symptoms that we're noting now, that doesn't mean that every patient has these exact symptoms.
Yeah.
Everybody can be very different with this.
So next we are going to touch on the interventions and how we decided which interventions to perform.
First intervention, we are choosing a manual therapy technique called effleurage. This is a soft tissue massage technique, really focusing on the skin, so a lot of light pressure. The reason we chose this technique for this patient is because we really wanted to loosen the pec group muscles up. The reason we chose the pec group is because typical bed rest patients typically have a more forward head posture with rounded shoulders, especially after being in the ICU for a few days, which is directly applicable to our patient. So as a reminder, Brooklyn will be portraying an 85-year-old male who has general deconditioning. We are unsure of his initial diagnosis, but we are starting with effleurage because it is a good way to reduce his anxiety, as well as increase muscle compliance and decrease muscle stiffness. Another added benefit of this is increasing his parasympathetic response by altering his heart rate and blood pressure, which we are unsure of his initial case or his initial diagnosis, but typically this is a very good thing for those patients in the ICU. So I'm gonna have Brooklyn lie down on her back for me. I have a few tools here with me. But before I do anything, before I include anything, I'm going to hand sanitize. And then I will introduce myself to Brooklyn. Brooklyn, I am Charlotte Pohl. I am a student physical therapist here helping you out today. We are going to be performing effleurage, which is a soft tissue massage technique. Have you ever had this done before?
No.
No, okay. We're gonna be focusing on some more intimate areas. Is it okay if I touch you in those areas today? You just tell me if you ever feel uncomfortable, if you'd like to stop, okay?
Okay.
So typically I will clear the patient for her contraindications. So I would ask, Brooklyn, do you have any allergies to any type of gel? Do you have any active malignancies or increased sensitivities in any area?
Nope.
And no lack of sensation?
Nope.
Great. These are just a few. I could keep going if I were more concerned about the patient depending on his diagnosis. So what I'm going to do first is test and retest. Big thing with this is we're really trying to loosen up those stiff pecs. So I'm going to do a muscle length assessment on his pec group. By doing this, I'm going to remove the pillow from Brooklyn's head. I'm going to ask Brooklyn to bring her hands up above her head, like so. This focuses on the pectoralis major and minor, and as you can see here, there is a lot more tightness in the area, or in the pec group. The way that I know this is by the distance between her lateral epicondyle lignon to the table. So what I'm going to do is take this measurement beforehand, and then I will repeat it after that modality is, or after the manual therapy is completed. So palpating here, we have about 4 inches here. So I would ideally document this in some form, but now we are going to get to the actual intervention. So using any type of medium, right now there's a body tissue deep cream here that I will be using, and for sanitary purposes I'm using a tongue depressor, and I will just take a small dollop and I will apply it directly onto the patient's skin. Yes, and ensuring patient comfort is number 1, so we are going to bring that pillow back. All right, and then Brooklyn, I'm going to ask you to move the first one there. Okay. And then I'm going to be applying some lotion onto your skin. Again, just let me know if you ever feel uncomfortable. Okay. So I am applying the medium directly onto the patient's skin here. I will remove this. And then I'm doing a very light massage here. So this can be done in different ways. I'm going to layer my hands just like so. And then I'm going to be running parallel with the pec major and minor fibers. So basically running in line, as you will see here. I will perform this for about 5 to 10 minutes. We are starting with this intervention because, like I said, we really want to loosen everything up here, as well as just calm the patient. Really reduces anxiety, is a good way for me to talk with the patient and introduce myself more. So I will lather this up here. Like I said, layered hand technique. This can be performed in different ways, but this is how I choose to do it in the smaller area. And then I will be really just pressing lightly into the skin, up and lateral, up and lateral, just like so. Really taking note of my body mechanics, ensuring that I am in a proper athletic stance here, because this can be performed for a long period of time, so I want to make sure that I am protecting myself as well. Afterwards, I will go ahead and wipe off the cream on the patient, as well as myself, and then I will retest. So once I wipe this down, again, this would be for 5 to 10 minutes, so we are speeding this up. And then I would go ahead and retest the pec major muscle length here. Perfect. Look at that, a lot of improvement. Same thing here. Going down. We are about 2.75 inches from the table. So that would be a positive outcome from the intervention. And then now we will go on to the next one.
My name's Brooklyn. I'm an SPT. Charlotte's going to be playing my 85-year-old deconditioned patient today. For our second intervention, we have chosen to do scapular mobilizations. For our first intervention, we chose to do effleurage on the pec to loosen it up. We're specifically focusing on posture for our manual therapies, because posture is really important in maintaining coordination and balance, which is really important for an 85-year-old patient. Especially when you're sitting in a hospital bed, you can suffer from poor posture. And if that's not corrected, unfortunately, it could get worse and worse and worse. So, like I said, we did effleurage on the pecs, specifically to fix those rounded shoulders. We're gonna mobilize the scapula today to hopefully improve. When we have forward rounded shoulders, our scapulas tend to be protracted. So we're hoping by mobilizing we can get more retraction. So I'm gonna start by testing her or his scapular range of motion. So the scapula does like subtle movements. It also does help the glenohumeral joint in some of the motions. But what I'm gonna do is I'm gonna watch from behind just so I can see her scapulas move. And Charlotte, if you could go ahead and try to bring both of your shoulders together in the front. Okay, so this is scapular protraction, and then I'm gonna have you try to bring both of your shoulders together in the back. Try to pinch your shoulder blades together. That's scapular retraction, great job. You can go ahead and relax, and then I'm gonna have you shrug your shoulders up just like this, and then down. Perfect. And then if you could please bring your arms out to the side just like this, just so I can watch how her scapulas move. All right, go ahead and go back down. Perfect. All right, so that is my test. Before I get into the scapular mobilization, I'm gonna clear my contraindications. So, hi Charlotte, my name's Brooklyn, I'm an SPT. I'm gonna be doing some scapular mobilizations on you where I'm just gonna be moving your scapula around, see how it feels. Before we get started, do you have any open wounds, any decreased sensitivity, any fractures in that back area?
Nope.
Okay, cool. I'm gonna take a look, examine the skin for myself, and then we're gonna get started. So, I'm gonna have you lay down facing me on your side, please. I did already hand sanitize. I did already introduce myself to the patient, give her a little explanation on what we're gonna be doing. And then I have this pillow here that I'm gonna put in between myself and the patient, and then I do have her scooch all the way forward, which, yep, perfect. And I'm gonna make sure I'm here so my patient doesn't fall off my table. So, is it okay if I touch you today? All right, cool. So I'm gonna go ahead and have her relax her arm just like this. And I'm gonna palpate for the lateral and medial borders of her scapula just so I have something to almost like grab onto. Okay, so I can feel that medial borders right here and then that lateral borders right around here. So with scapular mobilizations, it's actually quite simple. We're just moving the scapula. You can kind of see the shape in my hands. We're just moving this way for a medial glide. Her shoulder's kind of moving a bit as well, but that's okay. And then we're moving this way for a lateral glide. So the medial glide is gonna improve retraction of the scapula, which is what we want. And then the lateral glide is gonna improve protraction, which we don't really need, but I just wanted to show it. With the scapula, you could also do glides to improve downward and then upward. And then the scapula also does some rotation as well. So you can rotate it down and in just like that, and then up and out. And with this one, it's quite nice because you could actually like see the whole thing move. So just like that. How does that feel? I'm gonna check in with my patient as I go just to make sure everything's feeling okay as I mobilize. Okay. Just gonna focus on some medial gloss. All right, so once I'm done with this treatment, you can go ahead and sit up slowly. I'm gonna help my patient sit up because he's 85. All right, so go ahead, sit up and then swing your legs off the table this way. Retest is really important in this field, especially with treatments like this. So I'm just gonna go ahead and do the same things I had her do in the beginning. So Charlotte, if you could go ahead and try to pinch your shoulders together in the front and then pinch them together in the back. Great job. And then shrug them up, shrug them down. Great job. And then again, just bring your hands out to the side just like that. And I'm just gonna watch. It looks like she got more range of motion, especially with that retraction, which is what we wanted. So next we're gonna talk about exercises for our patient.
First exercise intervention, we decided on a sit to stand for this patient. As a reminder, we have an 85-year-old deconditioned male in the inpatient setting. We decided on a sit to stand test, specifically the 30-second sit to stand test, because we want to determine his lower extremity strength as well as his rep maximum so we can do proper dosage for him. So since this is a formal assessment, I will be reading off a script for the patient. And I also have a timer here that will be timing him for 30 seconds. So I already have applied the gait belt onto Brooklyn, really prioritizing safety here, so I will be here as guidance. But first, before I do anything, I will read the instructions for the patient. So, Hi, Brooklyn.
Hi.
My name is Charlotte. I'm the student physical therapist here. I'm going to be assessing you doing some sit to stands, okay? All right, so I'm going to say some instructions here. I just want you to ask if you have any questions, okay? I'll be helping you through this, but we're going to get started. So I would like you to sit in the middle of the chair if you can. Perfect. Place your hands on the opposite shoulder, cross at the wrist. Keep your feet flat on the floor. Keep your back straight and keep your arms against your chest. On go, rise to a full standing position, then sit back down. Repeat this for 30 seconds. I have a 30-second timer here. Now that I have read the instructions, I'm going to stand posterolaterally to Brooklyn so that I am here to support her if she needs. I will prop up the phone here so I'm able to see, and I will be counting in my head the amount of times that she stands over the 30-second duration. Does everything sound good, Brooklyn?
Mm-hmm.
Okay. So ideally I would have some form of tech or aid start the timer, but for now I'm going to start the timer and then I will say go to Brooklyn. So 3, 2, 1, go. All right, so that is 30 seconds. You can go ahead and have a seat.
Okay.
I would stop the timer before I talk to the patient. I would go ahead and write that number so I still have it in my head. She sat and stood 10 times, which 11 reps in 30 seconds is a healthy 85-year-old male average. So I would say he's doing pretty good. And then I would use that number to quantify the rest of my dosage. So for this patient, we really want to focus on endurance and making sure that he does have the strength in order to not present as a fall risk in the community. So looking at resistance training, I would look at 50 to 70% of that rep max. So of the 10 reps that he just did, I would base off that number and document it. And then to build endurance, I would really want to have high reps, 1 to 3 sets. So anywhere between 24 to 30 reps, 1 to 3 sets, and then making sure that we get that rest in there. Since our patient is very short of breath right now, just involved with the deconditioning, we would really start on the low spectrum of this endurance training. So probably closer to 1 set, closer to 20 reps, longer of a rest break of 3 minutes. And then ideally 5 to 7 times per week, but in the inpatient setting, it might be harder to get to that number. So could be more, could be less, but really want to try and build this guy's endurance.
For our next exercise for our 85-year-old deconditioned male, we chose marches because this is a great exercise to increase aerobic endurance, and it's also easily modifiable. So a march, can you stand up for me? Charlotte's going to be demonstrating as my 85-year-old patient. I have a gait belt on her because I would ideally like to use a gait belt during a session. A march is done by standing in place, getting those knees up high. You can put your hands here just for some feedback, and just like that. You can count each rep as a knee hits your hand. All right, perfect, thank you. Like I said earlier, this exercise is easily regressible and progressible. So to regress it, Charlotte, can you go ahead and sit down for me? I could have the patient do it in sitting. So go ahead and just march up in sitting. Again, put your hands up there and try to get those knees to touch your hands. Perfect. Just like that. And then this is an AirX pad. So to progress this exercise, I could have her stand up and go ahead and stand on this pad for me and perform the marches on the pad. This is great because it'll also incorporate a little bit of balance activity, and I would also be, ideally this one we would do in the clinic with a PT, considering that is also a balance exercise. Good job. And then if I didn't have an AirX pad or the patient doesn't have one at home, I could also provide him with some ankle weights just to do, or just to put on while he's marching, or we could work resistance band in there as well. Okay, you can go ahead and sit down. To prescribe dosage, ideally with our first session, I would like to see how many reps he could do and use that as my 1 rep maximum. So after seeing his maximum amount of repetitions that he can perform with good form, I would prescribe him to do about 50 to 75% of those reps. So if he could do 10, I'd probably want him to start with 5. 1 to 3 sets of 5. Probably would start with like 1 or 2 just because he's 85, he's deconditioned. Give him 1 to 2 minutes of rest in between. Again, probably on the higher side to start, and then do that 5 to 7 times a week.
So a modality that we would focus on for this patient would be heat. The reason we chose this modality was really just to decrease his anxiety and stress in the hospital. It's very common for people being in a new setting, just not being at home, to be a little bit more tense and just anxious about literally anything that they're going through. So we wanted to focus on that, increasing his parasympathetic nervous system response, decreasing sympathetic nervous system. So try and just calm him down a little bit. Depending on how he's feeling that day, we obviously are unsure of his diagnosis that brought him into the hospital. So we would want to clear him for any contraindications first before applying the heat. But we would focus mainly on the traps if that was bothering him that day. But another thing that we could focus on is low back. Very common in older adults just to typically have some low back pain, especially being in a hospital bed. That might not be the most comfortable positioning for him. So our idea was potentially having him lying, definitely not prone or supine due to his age, and supine due to the risks of burning or any sensation loss in his skin. We want to reduce any chance of burning for him. But if we were inside lying, that would also be good because we would adjust his posture and positioning, reducing any chance of bed sores or contractures along the lines of his positioning. So I would want to do this either 10 minutes before or after, depending on how he's feeling that day. And Brooklyn will talk about how we will communicate with him.
Yeah, so communication for this patient is going to be really important. Because he's 85 and because he's in the hospital, we want to make sure that we really use auditory and visual cues so he can hear and see everything, just in case one of those senses is diminished. That's really important. And then we're going to use a lot of repetition, celebrating the small wins because he is in a hospital. He's probably going to have some sort of like depression. So celebrating those small wins is hopefully going to help encourage him, make sure that he knows like he's doing a great job. And we also talked about utilizing the phrase, "show me what you learned." We think this is a great way for us to demonstrate something, and then we can see what he retained from our session, and that'll help us like correct any information that didn't really get there along the way. So we also are unsure if he has a caregiver. We're assuming so, or at least someone in the home who can help him out throughout the day. So we would want to educate that person as well, make sure that they are hearing and seeing everything that we're telling the patient. And we really want to just emphasize that any movement is good movement, and that movement for his condition specifically is going to be the ultimate medicine and what's going to help him feel better. Even though it might not feel good in the moment, it's really going to help him in the long run. So yeah, now for the follow-up plan.
So for his follow-up plan, we are going to really prioritize his aerobic endurance. We want to make sure that that shortness of breath, that dyspnea is starting to kind of hopefully reduce itself based off the exercises that we chose for him. So if we were going to progress, we did already see the marches and what that looked like, adding the AirX there to also get balance involved. But we could either add weights or more resistance training involved as well. Specifically with bands would be a little bit more realistic for this patient. So incorporating those into his marches, into his sit-to-stands, maybe more aerobic exercises just to build his endurance and overall get him back home.
Yeah, so since we're in an inpatient setting, like we said before, increasing the ease of his ADLs and just increasing his own independence is really what we're going to focus on, because we want him to get out of the hospital and be able to get home and be safe in his home, and also to be able to like shower and do his ADLs and get everything he needs to do in his home done safely. So that's our main priority, and that's ultimately what we need to focus on for discharge. So that is what our follow-up plan is going to be centered around.